Thank you so much, Arash. Is fine. I'm a pediatric cardiologist at Phoenix Children's. I run our exercise lab, and I'm the co-director along with Todd and Allen of our coronary clinic, which was really, designed to take care of children with coronary anomalies and Kawasaki disease, aneurysms, things like that. But we opened right as COVID happened. And so now we've become the coronary and COVID care clinic. So we see all varieties of COVID MISC patients. And so that's kind of by default become our secondary subspecialty besides coronaries. So we'll go through a lot of data. I'll get you guys very updated on what's going on with the athletes and COVID here. Let's see. I have no disclosures. And then there's the accreditation slide. Okay, so the goals of today's discussion for everyone, I'm going to kind of go through an overview of COVID, talk about MISC, multi-system inflammatory syndrome in children, because that's kind of our worst case scenario. We're going to talk a little bit about myocarditis and sudden death. And then I'm going to go through the literature about myocarditis in athletes with COVID-19. And there's going to be conflicting data and confusion. It's going to be a little bit of a roller coaster. And hopefully with a little bit of resolution, as any good story has, conflict resolution, and then a happy ending, discussion of real world application for people whose boots are on the ground and are seeing patients and dealing with athletes. And then the teaser for the sequel, a brief word on post-COVID-19 vaccine myocarditis, because that's a thing now, and another thing that I've had to become an expert in, again, purely by default, since I care for all these patients. So you guys probably know very well what happened with COVID. Back in 2019, in December, it was reported in Wuhan, China, and really the earliest reports were that there wasn't much that affected children. This was one of the first papers that came out of Italy, 7,500 children. Mortality was less than 1%, 2% ICU admissions. So their conclusion was that children were largely asymptomatic or mildly symptomatic. And around that same time, this was April of 2020, that report was published, we started hearing rumblings about Kawasaki-like illness happening in Italy and the UK, kind of the first areas that were hit with the wave of COVID. Italy reported, 30 times more frequent Kawasaki-like syndromes as they had before the pandemic. And we started seeing reports of coronary aneurysms, myocarditis, heart failure, arrhythmias, and we sort of identified this condition and named it multi-inflammatory syndrome in children, or MISC. So this is kind of our worst case scenario. All of these kids see me, we all clear them for sports, but I just want to give you guys perspective about kind of like what this looks like at its worst. So they've got some definitions from the CDC. There's multiple different definitions of this. Again, this is a brand new disease that we've never seen before. I'll talk about a little bit about the relation with Kawasaki, but it's fever, it involves multiple organ systems. The COVID exposure is usually about a month prior. And so this is a post-COVID inflammatory response. Now, the age is less than 21 years. If you're wondering, there is an MISA, which happens in adults, but it's far more rare. They don't tend to get the inflammatory storm that the kids get. There are some pretty typical lab markers we see. They're lymphopenic, thrombocytopenic, hyponatremic, very elevated inflammatory markers, and a very elevated procalcitonin, which is usually only seen in bacterial infection, but with negative blood cultures. I have a couple slides just side-by-siding it with Kawasaki disease, because most people have at least heard of Kawasaki disease. And, kind of the big things that I'll point out is that there's overlap. It's an inflammatory syndrome. We think Kawasaki disease is actually caused by an mRNA virus. We don't know exactly what it's caused by. And of course, SARS-CoV-2 is a mRNA virus. And the kind of the bigger difference that we've really seen are the age groups. Most of our Kawasaki patients are under 5. The MISC patients are anywhere from 3 months to 17 years, and they kind of like land the most common ages are kind of in that pre-teen, 10 to 12-year-old age. We see a decent number of teenagers that are getting MIS-C. LV dysfunction and shock are very common at presentation, as are GI symptoms at presentation. There's another slide. It goes through kind of the same comparison. Actually gives the ages, mean age 2, mean age 10 to 11. And again, the big difference is we rarely see Kawasaki shock syndrome with just traditional Kawasaki disease, and probably the majority of our MIS-C patients are coming in shock. They're hypotensive, they need inotropes, they need fluid resuscitation. So again, the early reports, we haven't had finalized data yet, even though this is, we're getting into about a year that we've been dealing with MIS-C. We don't know how many of them have myocarditis. In our research group, some people say everyone, which I wouldn't be surprised if that was true. But at least what's published on the MRI data is somewhere about 2/3. I'm going to be referring to MRI a lot, and to give you guys a brief background, at least in pediatrics, we no longer do endomyocardial biopsies to diagnose myocarditis. Just don't do it. So most of our myocarditis is diagnosed via laboratory studies, cardiac imaging, EKG, echo, and then there's some characteristic changes that we see on a cardiac MRI with the T2 signals, late gadolinium enhancement, hyperemia, edema, that can meet a certain criteria. They're called the Lake Louise criteria that are very typical of myocarditis. It's both a good thing and a bad thing, and I'll kind of share with you how it's turned into a problem for some of the athletes. But about half of the patients that we see present with decreased ventricular function. A lot of them present with valvar regurgitation, most commonly mitral regurgitation. Small pericardial effusions, we haven't had kids in tamponade. We see coronary aneurysms in about 20%. They don't tend to be giant aneurysms, but we have seen giant aneurysms in MIS-C. We've seen a lot more electrical conduction abnormalities in MIS-C than we did in Kawasaki disease. Tachycardias, bradycardias, ectopy, and we're studying this. I'm the PI on most of these here. Probably our biggest study is this one, MUSIC. Of course, it's an acronym for an MIS-C study, but we have about 900 patients enrolled in this. It's a multi-center study across about 30 sites in the US. So we're hoping to have some at least preliminary data out of this study network in the next 6 months to year, so that we, instead of these studies that I show you of 100 or 200, we have a little bit better idea of what's going on with our MIS-C patients. Here's an echocardiogram. This is a heart, as Dr. Sharp said when I showed it. It moves. And what you will note here is that there is decreased left and right ventricular systolic function. You can see the little Fliberty gibbet over in the right atrium. That's not endocarditis, that's a central venous catheter. But this child does have a small pericardial effusion. Same child has, start moving, let's go. There we go. Has a lot of tricuspid regurgitation, somewhere in the range of moderate to severe, probably moderate mitral valve regurgitation as well, okay? And just to show you some of the other imaging and imaging modalities that we use, here's some of the cardiac MRI images that we see. And this is just a scan looking at the systolic function, different patient. This is from a publication, so not the same patient. This is how they see the edema, hyperemia, necrosis, and scar to diagnose myocarditis. Same thing that I'm going to show you here. This is just from a different publication. This is the same T2 mapping that they did in the other image. It's just color mapped a little bit more colorfully. But again, they're looking at the T2 mapping. You can see this abnormality here. They're looking for late gadolinium enhancement that they see here, the post-contrast enhancement, and then again, more LGE in that same area from a different view. So this is short axis, this is long axis. Okay. And here's just an example of a coronary artery aneurysm that we see. In most young kids, we can actually see the coronary arteries really well by echo. And in case you don't know what all the squiggles are that are moving here, It doesn't come pre-labeled. You need a cardiologist to do this for you. But this is the RV outflow tract. This is the aortic valve. This is the left main coronary artery, and this is a giant aneurysm. It's about 6 millimeters, so probably triple the size of normal here. Some examples of electrical abnormalities that we've seen. I happen to pull these from my file, and I didn't notice that I pulled both of these from the same patient, but these are both the same patient. If you guessed this was a little touch of VT, that's exactly right. And this is something we really don't see in kids very much. It's actually atrial fibrillation. The good news, eventually I'm going to get to, because this all sounds awful, right? I've showed you decreased function, Valvar, like it looks terrible. AFib, VTAC, like this looks bad. But it does resolve, it does get better. I'll show you some more information and slides on that. I'll tell you that that kid that I just showed you with both the VTAC and the AFib, I had him on antiarrhythmics for maybe a month or two. I took him off and did a monitor, and he's been fine since. If that was a post-op patient, I'd probably have him on a year of antiarrhythmics. If it was you that showed up with those arrhythmias, you'd probably be on those antiarrhythmics forever, if not getting ablated. There is a little bit of good news there. These things tend to go away. Again, the small study, this came out of New York. They had the early experience. The COVID wave hit them first. 80% of their patients had at least a mild abnormality. And again, everybody had resolved at the 4-month follow-up. There was one child with mild dysfunction, one child with mild valvar regurgitation. The 80% that were mildly abnormal, 40% moderate to severe abnormality. Again, this is either regurgitation, function abnormality, or aneurysm, all resolved. So a little bit of good news. And basically what we do is supportive cares, immune modulators, IVIG, glucocorticoids, and time. So time is going to be really, really important here, and hopefully a good takeaway message for you guys. And this is our sports clearance algorithm that you may or may not have seen. This is what all the kids go through when they show up to the primary care physician, and they've had COVID-19 infection, and they try and risk stratify what they're doing and how much they're doing. So this what I've showed you guys is over here. It's the red. Severe ICU hospitalization or diagnosis of MISC. Okay, so we're going to look at now, kind of talk about what about these other patients, because these are kind of easy for you guys and a little bit less stressful for me, because before I let them, they get restricted for 6 months, and before I let them go back to do competitive sports, they get cardiac MRI, exercise stress test, they get the whole shoot and match. Okay, so the far larger groups of patients are these asymptomatic patients. Again, this is the vast majority. And then the small group with moderate symptoms, and what we're doing with them, and what their what their risk and of myocarditis and their risk of events during sports are going to be. So why do we talk about this with myocarditis? Because it's one of the most common causes of sudden cardiac death. One of the most common in athletes as well. This is a slide from Circulation, Barry Marin. This is one of an update to one of the registry studies that he has done. And really, if you look at it, there's a bunch of different causes of sudden cardiac death, but kind of the 3 most common, less than 35, so teenagers, young adults, hypertrophic cardiomyopathy, coronary arteries, myocarditis is number 3 on the list. Okay, and the mechanism that we're looking at is really ventricular arrhythmias. There is some incidence of heart block. It's far less than the ventricular arrhythmias, and it tends to be far more in the acute phase than the late heart blocks. But we can certainly see some late ventricular arrhythmias in myocarditis. So again, here's the first bit of this contradictory data to make everybody's stomach turn a little bit. So again, multiple registries, US registry, Italy, NCAA, US military. These are all different populations. They all have different incidents of myocarditis and their top causes of sudden death. Again, hypertrophic cardiomyopathy tends to be the top one, unless you're in Italy, which is ARVC. It's just genetically far more common there. But this study, they looked at a review of 2,406 causes of sudden cardiac death across multiple registries. 97 were myocarditis. 9 of those were seen by a cardiologist and not diagnosed by myocarditis. Oops, we didn't do a very good job. Symptoms were non-specific, so we just kind of missed it. This is kind of one of the problems with myocarditis, at least non-COVID-19, non-SARS-CoV-2 myocarditis, is it can be mild, it can go undiagnosed. The child goes back to sports, goes back and exercises, and then has an event. So this is what we're trying to prevent. This is the whole reason that we're talking about this, is because we don't want a child that has a sudden, or a young adult that has a sudden death event on the field. That's the worst case scenario, and this is what we want to avoid. So what we've seen from the adult hospitalizations, again, this is not from MIS-C, but just from COVID, SARS-CoV-2, it binds directly to angiotensin converting enzyme. That's not nice because it induces myocyte death. Not nice. So adults, the ones that have respiratory distress, have any sort of respiratory support, 50% of them have troponin elevation, and 87% of them require pressors. So by the time their COVID's getting bad enough, they need some sort of respiratory support, they need a vasopressor along with it too. And then this is still kind of evolving. There's a huge range in what's come out in the adults, but even looking months and months out after their COVID infection, there's anywhere from 20 to 80% have had evidence of myocarditis on their MRI. And just to give you, some sort of perspective, if you're looking at, whatever other virus, we're talking 1 in 100,000, 1 in 1,000, very, very, very low incidence of myocarditis with these others. Again, we're going to talk adults. A little bit different in kids. It didn't affect kids the same way. And again, we're talking about the non-MIS-C patients. We don't think it's zero, but the initial data in kids and young adults thought it was somewhere between 20 and 30%. And this just caused panic in the sports world. And if you guys are college football fans, you probably remember this, right? Anybody remember this? Trevor Lawrence, he was ruled out for the game against Notre Dame because he was going through the COVID, post-COVID testing protocol that the NCAA had. So he wasn't allowed to play. We don't have details if he had myocarditis or exactly what was going on with him, but we knew he had COVID. He was going through the protocols and they didn't let him back in. So the NCAA made a really big deal out of this, and I think appropriately so. They didn't know what was going on. The world was upside down. 20, 30% they thought may have myocarditis. They don't want athletes to die on the field. Totally appropriate at the level of information that we had. And then we started to get more information. So this came out this year in March, and this was from the professional sports leagues. So NBA, MLS, MLB, NHL, NFL, total of almost 800 patients. These are not young athletes. And, a lot of them are, but the age range here you'll see goes from 19 to 41. We got some 40-year-old hockey players in there, kind of pushing our numbers up. But overall, what they had was the rates of abnormalities were low. The total that they ended up with, anything abnormal, was somewhere around 2 or 3%, and they had 0.4% with abnormal MRIs. Far better than 20 to 30%. And then we had another big registry study come out. This is from the Big Ten. So these are all the Big Ten schools. They decided to look at cardiac MRIs on all of their COVID positive patients. So they had a total of 1,597 cardiac MRIs. They also, had another, 1,300 COVID positive athletes they didn't get MRIs on, but 1,597 MRIs, big study. What did they find? Here, it's probably here. 9 had clinical myocarditis out of 1,597. Fantastic, low number. 28 had subclinical myocarditis. the kind of tricky part is that the ones with the clinical myocarditis, at least, this is good for us to figure things out. The ones with clinical myocarditis all had symptoms: chest pain, palpitations, dyspnea. They had something, okay, and they almost all had abnormal. They actually all had abnormal MRIs, and some of them had residual findings at their follow-up. The subclinical ones, no symptoms. One of the tests was abnormal. All of these MRIs were abnormal. And then they had this other group of subclinical possible myocarditis, normal echo, normal EKG, normal troponin, no symptoms. All of these had normal MRIs. Now, this is a huge number of their patients. And so they went through and they said, what's the best way to clear these patients for sports? And so they went and said, what if we just looked on symptoms? What if we did echo? What if we did this? And then what if we did cardiac MRI imaging in everybody? I'm sorry, I need just 1 second, please. Hello? Yes. I'm in a meeting. Can I call you back, please? Thank you. Sorry about that. So they went through and looked at different strategies on how they could have diagnosed these patients and what the numbers they would have gotten out from just looking at symptoms, just looking at testing, or doing cardiac MRIs on everybody. And their conclusion, which probably maddened all of us in the sports cardiology world, is this is reasonable. Data suggests 1.8% of athletes with prior SARS-CoV-2 infection are both asymptomatic and have subclinical myocarditis. Okay. In our view, the role of CMRI imaging and routine screening for athletes' safe RTP should be explored further. So they actually are trying to be proponents to do cardiac MRIs on everybody. You know, this is stuff that becomes highly problematic. You know, I've got a cardiac MRI machine here at Phoenix Children's that's already running 2 months behind, and I'm very selective about who I send for an MRI. So you know, articles like this start to be really problematic because there's no way that we can even do echocardiograms on all of the athletes in the state, much less send them all for cardiac MRIs. It's just, you know, distance, numbers, everything. It's just not going to be feasible. I know the senior author on this. He's one of the adult congenital cardiologists, and we run in the same circle. So I'm going to give him a good punch for suggesting that we MRI all of our athletes. So why don't we do that? Why didn't we change everything? Why didn't we start MRIing all of our athletes when this came out? There's a couple reasons, and this is the roller coaster, the up and down. But basically, there was a study, and this had actually been published prior to the Big Ten registry. But everyone circled right back to this as soon as the Big Ten registry came out and said, hey, remember this one from Circulation? This is a research letter. It's a little bit more of a kind of a less formal presentation of the data. But basically, they said, you know, we can see some LGE and some changes in athletes' hearts. They're different than normal children. And if you don't have a control group, if you're not comparing the athletes to a control, you may be overdiagnosing myocarditis. So they had almost 60 COVID positive athletes, 60 athletic controls, 27 healthy controls. And indeed, if you looked at the athletes and the athletic controls, there was an area of LGE that was seen in 22% of the COVID positive athletes, 24% of the athletic controls. Now, the Big Ten registry didn't have 24% positive. It was, you know, depending on what number you look at, somewhere between 1% and 3%. But the idea is, you know, you didn't have a control population. So some of those subclinical things that you saw, were they real, or are you overdiagnosing myocarditis by cardiac MRI? It's a great question. The next counterpoint was actually out of an infectious disease journal. It's a small but a nice study, and a lot of us had pretty good sense that this is what was going on. These guys just put their data together, but they looked at myocarditis in their center as a retrospective study, looking at outcomes of myocarditis related and unrelated to SARS-CoV-2. And basically, here's what they found. Fulminant myocarditis happened in the group that was not related to SARS-CoV-2, so like adenovirus, influenza, those sorts of myocarditis. And those with SARS-CoV-2 or COVID myocarditis, inotrope duration was shorter. LV systolic function was improved. They looked at day 3 in significantly higher numbers, and there were fewer with adverse outcomes in the COVID. So their conclusion, again, small retrospective study, hard to make big sweeping conclusions, but basically they said, hey, the patients that had myocarditis related to COVID, they tended to have shorter inotrope course. Their LV got better. Like they tend to have kind of better outcomes than the adenoviruses and some of the other bad things that we see. So that's a small study, a little bit hard to believe that, but this is big data. I pulled this yesterday. This is from the CDC website. You can use the link. You can go pull the data yourself. It's updated every day. You can look at it by a bunch of different ways. Here are COVID and MIS-C cases and deaths by age. I will point out to you here the pediatric group, all the way to 17 years of age. Altogether, they make up less than 0.1% of all COVID-19 deaths, okay? And if you look at the 18 to 29-year-olds, 0.6%, okay? So at least this jives with what we're seeing, that these kids get better, that they're less severe. We haven't seen a lot of, there are some deaths. We can't say that we haven't had COVID deaths, but they're not as severe as, you can see the proportion of 85-year-olds that are infected and the number of deaths. It's really, really much worse in the older adults. Lesson, don't get old. And then just to follow up our patient, if these will both play, here we go. Here's the patient I showed you, decreased function during hospitalization. Here's 30 days later. Function's totally normal, effusion's gone, central venous catheter is out. Here is that ugly looking tricuspid valve regurgitation, and then 30 days later, it is now resolved. And here is the mitral valve regurgitation. And again, we had that moderate mitral valve regurgitation, and 30 days later, his heart is completely normal, which is fantastic. And as I told you, that child that I showed you with both the AFib and the VTAC, better within a couple months. So, the bit of conflict resolution, and this is kind of the roller coaster that we've been through, is we've got gaps in our knowledge. There's still, this is a new disease. It hasn't been around for decades. There's a lot of stuff we're scrambling to learn about it. There's a lot of stuff we don't know. We think that the incidence of true myocarditis in asymptomatic or mildly symptomatic children with COVID-19 is low, single digits, less than 1%, 3%. It's something very low. It's not 20, it's not 60%. We know that it resolves or improves over time. Time helps. What we don't know is we don't know the implications of mild and subclinical disease. That all of those subclinical cardiac MRIs with no chest pain, no symptoms, no echo, no EKG changes, normal findings, we don't know the clinical implications of that. But as I showed you, there are not a high number of deaths from COVID and MIS-C in children, and we really have not seen an increase in the sudden cardiac death rate, at least anything that's been published or presented in the news and social media. And as you guys know, these are usually big deals when they happen. They're not ignored if they're all over the news, even though they tend to be fairly rare events. And the athletes do go through some screening. They don't all get cardiac MRIs. But here's what they do get. They should answer some version of this 14-element AHA screening list. This may not be this direct list, but these are the questions on the AIA form. Okay, have you had chest pain, unexplained syncope, dyspnea, palpitations with exercise, a couple of other questions about the family history, physical examination, and then they go through this sort of screening that we designed. Really, if there's no red flags, they're mildly symptomatic, asymptomatic, We don't really do much. They go through a 10-day return to play progression. And kind of the only kids that we've done workup on so far to look at things are the ones, besides our MISC patients, are the ones that have had more moderate disease, prolonged fever, and then they'll go through some testing, and some of them will end up getting echoes and referred to us for further evaluation. And this is pretty in line with what, again, despite the data that's been out and the conflict, this is pretty well in line with what a lot of other children's hospitals are doing based on the available evidence, which is mostly expert opinion. And then this is the return to play progression that you guys are probably familiar with. It's a 7-day. This is pretty standard. Okay, so they're cleared for sports. So again, what do we do? And this is just kind of a summary of what we've talked about here, is that, just understand there's some conflicting data here. We think we can risk stratify them based on the severity of their COVID, but some of them will have MRI changes, and we don't know what the risk is, but we really have not had a significant increase in sudden death in athletes. I've given this talk to athletic, or version of this to athletic trainers. I've given this to pediatricians around the Valley, and kind of your real world, down to earth advice, at least for people in your guys' realm that are maybe on the sidelines or dealing with athletes, is just keep these things in mind. Know your athletes. Is there someone you should worry about that had recent COVID-19 or that's been sick, had something going on? Wherever you are, just know your facility. I work at in a stress lab. I have very high risk patients. I know where my code card is. It's right outside my door. I know where my help is. It's right outside my door. So basically, have an idea of where those are. Is there an AED? Is there anyone else that knows BLS, ACLS PALS that can support you in case you're at an event and there is someone does have symptoms or a problem? And then if you're engaging in these athletes and talking with them, providing them care for their orthopedic problems, if they're talking to you about other things, sometimes this will go to the athletic director or one of their trainers, but if they're talking to you and they're telling you they've got cardiac symptoms, please don't ignore them. If they tell you they've got chest pain, palpitations, tachycardia, they've passed out, they've got new dyspnea, they can't catch their breath, something's changed, they've had COVID before, don't ignore it. Don't think that it's just fine. Those are just like those little early red flags, and get them worked up. And we try, and I tell all my patients, hey, be honest with me. Tell me what's going on with your body, and I'll get you evaluated. And it doesn't automatically mean that your season's over and that you're excluded from sports. I won't Trevor Lawrence you, basically. And here's an example. This is a child. I literally tested this patient, saw and tested this patient last week. 15-year-old COVID back in December. She actually had a pretty reasonably concerning COVID course. She had fatigue, lost her sense of smell and taste. She had 3-4 days of fever. Her pediatrician actually checked the troponin during that time, and she had mildly elevated troponin. So she probably had myocarditis, probably mild, but she had it. She didn't have cardiac evaluation at that time. She probably should have. But anyway, she's a competitive athlete. She does track, she does cross country. She returned to exercise and she's out of breath. She can't perform like she used to. She's getting dyspnea on exertion, and she's getting chest pain when she exercises. Came in to see us, EKG's normal, echo's normal, repeat troponin is normal. I had a feeling that this was all fine. I sent her for a CPET to prove it. Here's her CPET. For those of you that are familiar with it, she had a VO2. This is the red line over here on panel 3 of the 9 panel is the VO2, and there's her predicted. She's well above it, 120% predicted, well-trained athlete. Cardiopulmonary response, totally normal, very normal looking 9 panel. Spirometry is normal, EKG is normal. So we cleared her to return to sports, non-cardiac chest pain, and maybe a little bit of changes in her conditioning. She was, to be honest with you, her VO2 was probably 125% predicted last season, and now that she's down to only 120, she feels like she can't do as much because she lost that 5%. And these athletes are very sensitive to it. So again, not all the symptoms are pathology, not everything's bad. But when we do have an athlete that's got symptoms, we like to make sure. I had a pretty good idea that she was fine, mostly because of the timing of her COVID infection. We're testing her, last week, and her COVID was last December. So even if she had MIS-C, it should have been long enough for everything to go away. Post-COVID vaccine myocarditis. This is the teaser for the sequel. This was big in the news when the COVID vaccine was released for the 12 to 17-year-olds. There is some incidence of myocarditis. It is currently reported by the CDC at the highest rates at 50 to 60 cases of myocarditis per 1 million doses of vaccine administered. Okay, it's very rare. That may change because again, we're vaccinating more and more adolescents. Tends to be in males, tends to be after the second dose. Chest pain is in most common symptom. 99% of the patients have chest pain. They have a mild course and recover quickly. Almost all of them have normal function, but they all have abnormal troponins, and I'm assuming they all have some sort of inflammation in their heart and myocyte death. It's a little early. We're in the process of a couple of multi-site publications that just looking at what's going on here. We've not had any really bad outcomes. One of our studies that we're putting together is about 57 sites that have pooled data. There is one patient that we had between those 57 sites who required CPR and ECMO, and that child survived. So it's very rare to have bad outcomes, but we just don't know. And as a precaution, I am actually restricting these patients from competitive sports. It's not the end of the world, but again, if you've got a symptomatic child, don't go digging for this, but if they're telling you they've got chest pain, they've got some of these other symptoms, they're within 30 days of a vaccine, have them get evaluated. They can either get evaluated by their PCP or in the PCHED here. Okay, I think that's my last slide. And I'll stop with that and take some questions. That's my email. That's my nurse coordinator, Amy. That's her number. If you, for some reason, need to get a patient in to see us in the coronary or COVID clinic, she's the pathway in. If you've got random intellectual questions and you want to email me about things, you're welcome to do it. And again, thank you very much for inviting me to present to your group this morning.